Hi, my name is Hannah and I'm a student physical therapist at Campbell University, and I'm going to be demonstrating how to assess posterior and anterior innominate rotations, which are types of pelvic obliquity. So if you have an anterior innominate rotation, this part of the pelvis is rotated forward, and if you have a posterior innominate rotation, this part of the pelvis is rotated backwards, while the other side remains the same. So the four tests, the first one is called the standing flexion test, and first you're going to start with your patient in standing, and lift the shirt and tuck it under so you can get a good look. And you're going to palpate the PSISs and make sure you're at eye level. So you're looking to see if the PSISs are level or if one side is superior to the other. And then you're going to have the patient bend forward, and while maintaining the eye level, keep your hands on the PSISs, and you're looking to see if one moves higher than the other. So go ahead and come back up and do that one more time. Okay, the one that moves higher is indicative of a hypomobile SI joint on that side. The next test for hypomobility is to have your patient seated. I'll leave the shirt untucked. And again, you're going to palpate the PSISs at eye level, and you are looking to see if if the PSISs are level again, or if one side is lower than the other. So like you said, with best posture, you're going to get down and look, and you're looking to see if one is lower than the other. The lower side is indicative of a hypomobile SI joint on that side. If you find that one side has a hypomobile SI joint, this is potentially indicative of a pelvic obliquity on that side. To further delineate if it's an anterior or a posterior innominate rotation, the next test is the supine long sitting test. So you're going to have the patient lay down on the back. And the first thing you're going to do is we're going to look and palpate the ASISs. And you're just looking to see if they're level. A discrepancy increases the likelihood of having a pelvic obliquity. Then you're going to have the patient bridge, so go ahead and bring your feet in and lift those hips up off the table. Good. And come back down. And then you're just going to give some long axis distraction, and you're ensuring that the pelvis is in its resting position. And then the next step, you're going to compare the lengths of the legs by palpating the inferior aspects of both medial malleoli to see if the patient has a leg length discrepancy. So you're going to get right down over the top of the malleoli, put your fingers underneath, and you're looking to see if one leg is longer than the other. To determine if the patient has a true leg length discrepancy or a pelvic rotation, have the patient come into long sitting. If it is a pelvic rotation, the legs should even out. But if it's a true leg length discrepancy, the patient will remain uneven. So then for the prone knee flexion test, you're going to have the patient turn over, and you're going to ask the patient to lay there with their knees fully extended. And then you're again comparing the lengths of the legs by palpating the inferior aspects of both medial malleoli. And again, you're looking for a leg length discrepancy. Ask the patient then to flex the knees to 90 degrees with the ankles dorsiflexed to neutral. And you're going to compare the height of both heels at eye level. And a positive test is shortening of the affected leg when the knees are extended. That is then corrected when the knees are flexed. For both the supine long sitting test and the prone knee flexion test, the side with the shorter leg that evens out suggests a posterior innominate rotation on that side. But the side with the longer leg that evens out suggests an anterior innominate rotation on that side, but paired with both positive tests for hypomobility. So, in the research for tests for pelvic obliquity, Riddle et al. Found that the long sitting test confirmed the diagnosis of SI joint dysfunction more times than it did not, but it did not confirm the diagnosis in all the cases. Another researcher, Bemis et al., examined the inter-rater reliability of these four tests of pelvic symmetry and SI joint movement for identifying individuals with pelvic obliquity in a blinded study using 34 therapists, but determined that the reliability was too low for clinical use, but that potentially the therapist training for these tests can be unclear. Perhaps better education of the four tests will improve sensitivity and specificity of the tests for more clearly identifying SI joint dysfunction. As therapists, we should take into careful considerations our findings during evaluations and perform an entire battery of tests before coming to a conclusion about our patient's diagnosis.